Okay, here it is, setting up meeting, 30 seconds, 29, 28, 26, 25, 24. Welcome. Today is Saturday, February 6th. My name is Kevin Fitz. We are now having another episode of Fittsian Dialogues. Today, our special guest is Bob Nikkel. Bob Nikkel previously was a mental health administrator for the state for many years and also served as the health commissioner for the state for many years, as well as many other things. Bob, why don't you take it away and give us a little bit more information about your vita and what you're going to talk to us about today. Bob's talk is titled The Road Less Traveled, 3 Decades of Progressive Mental Health Reform and Leadership. Thank you very much. Take it away, Bob Nikkel, and then we'll go back from there and have the introduction as soon as you tell us a little bit about yourself. Thank you.
Okay, Kevin, thank you very much. It's good to be here. Really appreciate the opportunity to spend a little time with the Fittsian Dialogues, and I'm really kind of interested in the topic of progressive mental health reform. I do a certain amount of blogging on that on the Mad in America website. And I'm sometimes viewed as kind of a hopeless case because I still have some hope that the mental health system can get out of its doldrums, really get serious about peer supports and recovery and community. And I'm continuing to do that. There are people who are so angry at psychiatry, and I don't blame them, that they have a hard time thinking that there's any hope for the system. But today's presentation really does try to focus on hopeful things that have happened in the past. And those are things that I think lay the foundation for future mental health reform, progressive mental health reform. So my own history, I've been in the mental health and addictions field for about 50 years now, kind of surprises me. I started off as a psychiatric aide, and I've done pretty much everything between that, to residential care to alcohol and drug treatment, and then mental health case management. And then I began to let myself get into supervision and management. I never had any intention of doing that. And I often refer to myself as the accidental commissioner, because in 2003, I was asked to step into that. And there's a little story behind that, which I won't go into. But I spent about 6 years as a state mental health and addictions director. It was a fascinating experience.
What year was that when you started that? What year did you start as that position?
Yeah, I started that in 2003, and I was finished in 2008. I spent a couple of years studying integrated healthcare, mental health, addictions, physical healthcare, and dental care. I wrote what is almost a small book on that subject. If anybody ever wants to see it, I can share it. I spent a couple of years being the director for Jefferson Behavioral Health down in Southern Oregon. And then about 5 years ago, well, let me back up just a little bit more than that. In April 2010, I ran across a book called Anatomy of an Epidemic. And I'm guessing that most people on this podcast are aware of that. Robert Whitaker wrote it. It kind of knocked a lot of us in the head. We started, along with Robert, the Foundation for Excellence in Mental Health Care, and I was a founding board member of that. And about 5 years ago, Bob Whitaker, who I'd gotten to know, asked me to do one of his dreams, which was to direct a continuing education project. So my current main assignment is to direct the Mad in America continuing education program. We've been doing that, like I said, for about 5 years. About a year and a half ago, I was asked to be the chair of the board of Dual Diagnosis Anonymous of Oregon. So those are my main academic. Technically, I have an appointment to the Oregon Health Sciences University Department of Psychiatry. But when Gina and I started getting involved with Bob Whitaker, we suddenly stopped getting invitations to go speak. So that tells us something about one of the issues I think exists in Oregon, and that's the whole issue of training our psychiatrists, training social workers, training everybody else that works in the mental health field. I think actually the peers have done a much better job of catching up with things, because in many ways the peers have been doing this for I think decades.
Yeah.
So we're going to try to talk about what I see as what progressive leadership in mental health reform has done, and it's involved people at many, many different levels.
Okay, listen, so what I want to save time for question and answer. So why don't you move forward with your presentation at 12:40? We'll pivot to question and answers. I'll read the questions from the chat or live from Facebook, and we'll go from there. Great. Again, tell us the title of the talk and take it away, Bob. Thank you very much for being here.
Okay, the road less traveled, historical foundations for 3 decades of progressive mental health leadership in Oregon. I should say too, there are several people who are on this podcast who I have known and worked with for 30 years. Two of those are Kevin Fitts and Michael Liebachek. I've also known Jack Hotchek for almost that long and continue to be in a lot of contact with the 3 of you and others in the progressive reform movement. The beginning point of what we call mental health in Oregon, or in my opinion, worse, mental illness, is obscured in the several thousand years before the white man showed up here. It's important to consider what's become known as mental illness by the white man has been unusual or even unknown by Native Americans. And one reason I say that is that the last name of a person who was the first white man with mental health problems who came to the attention of Native Americans became a part of Chinook jargon as designating a mental affliction. It appears from what I can see that people in Native American tribes implicitly recognize the value of community supports for people with these challenges because they were accepted into their communities apparently rather than ostracized and institutionalized as we've done. The story of Archibald Pelton, the man whose last name entered Chinook jargon for mental afflictions, goes like this. And this is according to an article written by Olaf Larsell in 1945 in the Oregon Historical Quarterly. His story is that only a few years after the Lewis and Clark expedition in 1804, a massacre took place in the Snake River Territory. There was one survivor, and it was Mr. Pelton. He'd become mentally ill, or demented as they called it at the time. And as the lone survivor of this massacre, he was captured by the Native Americans, but then rather than executed or harmed, he was cared for until he was recovered enough to join the John Jacob Astor Party and travel all the way to Astoria with his group in January 1812. So in addition to his name becoming part of the Chinook language, his recovery, from what I can see, was the earliest recorded historical example in Oregon of a person in recovery. You know, at times we think maybe we've invented recovery and peer supports and community. And I think it goes back at least 200 years. The other possibly more familiar story is that of John Day, who arrived in Astoria about a month after Mr. Pelton did. And he too recovered enough that he was able to begin his journey back to the eastern part of the United States in the spring. So here then are the first 2 white men with mental health problems who recovered. Excuse me. Shortly after the establishment of the territorial government at Champoeg in 1843, several laws were passed that spoke to how Oregon settlers viewed people with mental health challenges. And just one example of this was a law that specified that a mentally ill person should be, quote unquote, let out publicly to the lowest bidder to be boarded and clothed for 1 year. It's quite a way of dealing with people who have mental health issues. Within a few years, Oregon did start down the path of institutional care when Dr. John Hawthorne opened a private institution in Portland. It was between 1st and 2nd Streets in Taylor in the fall of 1862. And by all accounts, he operated a very safe, sanitary, and efficient asylum. But in 1883, the Oregon Insane Asylum, quote unquote, was opened, and 370 persons by then were in Dr. Hawthorne's facility and were transferred from there to Salem. By 1958, the state hospital census peaked at over 5,000. I got to know one of the pivotal figures in Oregon mental health history, and I think one of the really, the earliest reformer was Dr. Dean Brooks. He came there in 1947. He'd been in the Navy during World War II. He'd done a residency in Akron, Ohio, and I'll mention something about that a little bit later, but he came to Oregon and he served as superintendent from 1955 until he retired in 1982. It's obviously 27 years. That's almost an unknown tenure for a superintendent. The family asked me to spend time with him every Friday before he passed away. He was in his 90s by then, but his memory was excellent. He'd never really told a lot of the stories that he had. And one of the first things that he told me, though, was that his guiding mission statement was very simple, and that, quote unquote, it's all about the patients. You know, and those words get slung around a lot, along with words like recovery and peer supports. But everything I learned and heard about Dr. Brooks was he really meant it. And I'll give you a couple of examples. When I asked him to tell me what his greatest accomplishment was, it was that he started what he called the Superintendent's Committee in 1960. So that's what, almost over 50 years ago. What he did was he invited a patient from each ward, plus others who were then invited later by the patients, not the staff, to attend the meetings. And the most who ever came to a meeting was 75. I think that's a pretty impressive accomplishment, particularly in a state hospital. An example of the kind of issue that the committee raised was the fact that hot coffee was being served on one ward in the mornings in wax paper cups. This is scalding hot coffee. And Dean, when he heard about it, was incensed. And Dean could get pretty angry. I really enjoyed that about him. So what he did was he had one of those wax paper cups filled with scalding hot water, and he took it to the responsible person, the service manager for food in that unit, and he held it by the edges so it didn't hurt him, but he just handed it to her, and she grabbed it, and she screamed in pain and said there was very hot water in there, and Dean said that made his point. That didn't happen anymore. I could tell a lot of other stories, and I will tell a few of them, of the things that he did, and they're quite far beyond what most people remember about him, and that is that he allowed One Flew Over the Cuckoo's Nest to be filmed at Oregon State Hospital. And he also acted in it as Dr. Spivey. But some of the other things that I think were really noteworthy, and I could go on for hours telling you stories because I spent so many hours with him. But he started the first AA meetings at Oregon State Hospital. And I mentioned that he'd done his residency in Akron, Ohio. And those of you who know AA history, that's where the founders of AA were, Bill Wilson and Dr. Bob Smith, and he got to know them. So he came in with some additional experience that led to him founding that, setting up that first AA meeting. Another thing that he did, which gives an example of the kind of things that were going on in the state hospital, he stopped gang showers. Apparently they were putting people in showers in groups, showering them down, and then they would have to go back home. A pretty inhumane, disrespectful practice. He stopped staff from collecting all the shoes at the end of each day. They would be put in a bushel, and the next morning they would be handed out. And I'm not even sure if they always fit patients. One of the things that he told me was that he had someone ask him to make the state hospital a Christian hospital. Now, Dean was a longstanding devout member of the Episcopal Church, but what he told them was, and this is a quote, "God damn it, get the hell out of here." So Dean was really quite a character. He invited patients to attend staff meetings, something that had never been done before, and I'm not sure it's being done now, as a matter of fact. He started the mountaineering program in which patients and staff went off together, and there were times he told me when patients were actually holding the ropes and staff were up on the side of the cliff. He said, it takes people to help people. And I think that's a pretty good definition of what peer supports is really all about. My favorite story about him was one that he told when I asked him what he thought about Thorazine when it came along in the early 1950s. So he said that they put one of the patients on it a little later And he was on it for about 6 months. He was a patient that staff said would never be discharged. They would never even talk discharge. But 6 months later, after having the patient on it for that long, the staff came to him and they said, Thorazine has worked a miracle. We're ready to talk discharge for this patient. Dean, being who he was, who was very much in touch with the patients, pulled the patient aside in the hallway. And he said the same thing to the patient that the staff had said to him. And he said, how did you feel about it? And the patient looked at him and had enough trust in him to say, I've been cheeking them the whole time. In other words, he hadn't been taking the meds the whole time. So Dean's comment to me was, so Bob, who in the hell are these medications for, the staff or the patients? And I think there's a lesson in that that says that expectations and hope for people who are struggling make a huge difference. And in my opinion, I think they make as much and probably more difference in our use of psychiatric drugs. And if you follow Bob Whitaker at all and the webinars that I've been doing over the last 5 years, I think it's real apparent that we believe there may be a place for medication sometimes on a short-term basis. And maybe some people need them for a long time, but the research is really clear that most people do better if they can get off them, particularly midterm to long-term. The outcomes are actually much better. If you want to find our Mad in America Continuing Education Project, we have Peter Gesche, we have Sandy Steingard, we have a number of other people who do presentations on that. Let me just put in another plug for the Continuing Education Projects. I don't think most people are told what medications can really do. They may be told that they could get tardive dyskinesia, they might get a dry mouth, they might even get restless, but I don't think they're really told very much information. And we started that series with 4 people with lived experience, and every one of them said that they'd never been told nearly as much as they needed to know about the medications. One of those people was Malcolm Aquinas, and I'll mention him a bit later. Malcolm has done a couple of the webinars for me and always does a great job. I think I should move on and talk about some other key state hospital superintendents, some of whom you may have heard of and some of whom you may have not. George Bacek was somebody who came along, I think, and I'd have to check this, but probably in the 80s. Maxine Stone and Dr. Satya Chandragiri were the superintendent and chief medical officer out at the Eastern Oregon State Hospital. One of the stories that I love about their work there was that one day when I was in the mental health director position, I got a petition from 160 of the about 250 patients telling me we needed to change the name to Blue Mountain Recovery Center. And we did that. And unfortunately, in my opinion, the one state hospital that was actually working pretty well was closed. And I think that was really a bad decision. A few years before I started working at the mental health division, I got to know Garrett Smith. And Garrett, I think, is a legend. Garrett had a history of having been diagnosed with bipolar disorder. He also had had some alcohol and drug problems. He also had a master's degree in business administration. He was a brilliant man. I know Kevin knows him well. Michael Ibachek knew him well. And Garrett had founded a nonprofit organization called the Mind Empowered Incorporated, MEI. And it was a totally peer-run nonprofit organization. I had actually gotten to know Garrett a few years before that because I was directing an NIMH dual diagnosis demonstration project in Salem. And Garrett was my research assistant. He did an excellent job at that. So Kevin, Michael, Scott Snedecor, and a few others ended up being staff in a project that MEI started called the Community Survival Project. It was one of the earliest programs that was entirely peer directed, peer planned, peer directed. And they were trained to be case coordinators, case managers, whatever you want to call them. And then they were assigned 25 to 30 of the most difficult to discharge people at Damage State Hospital. And it worked, and it received national recognition by the U.S. Surgeon General's report in, in 1996. Just a side note here real quick. I was asked by David Edwards to go to work at the Mental Health Division in 1990, and they wanted me to help develop acute care units in community hospitals rather than putting people in the state hospitals for their initial episodes. And, you know, that sounded interesting, and I was ready to make a change. And they said, by the way, if you want to be the coordinator for the Community Survival Project, and they explained what it was to me, you can do that too. It's kind of a side assignment. And I said to myself, you know, if the state hospital is, or the state mental health division is crazy enough to try something like that, I might fit in for a while. And of course, 18 years later, I was dismissed from it, which I'm kind of proud of. And there's another story behind that, which I won't go into. But it's noteworthy that Michael and Kevin and Scott and some others continued in a variety of advocacy roles. And sadly, as most of you know, Scott passed away in 2019 and is missed by everybody who knew him. I wanted to mention a few of the state leaders in the state government who I think laid the state's administrative and fiscal foundation for establishing this MEI project and other creative projects. And I'm just going to name some of them. And it's not all of them, but there was a mental health commissioner by the name of Dr. Rich Lippincott. His wife, Lucy Lord Lippincott, was a person who had been diagnosed with bipolar disorder. And I think Rich really sent the message that it was perfectly fine for us to work really closely, have friendships, and sometimes even marry people who had bipolar disorder. I think he set a good example. Others that I wanted to mention were Barry Cast, David Edwards, Loree Krieger, Dan Barker, and Vicky Scria. These are largely, I'm afraid, unknown bureaucrats by now, but they focused attention, funding, and administrative leadership for progressive mental health services like Mind Empowered, housing, which Vicky Scria worked on for a number of years, supported employment, supported housing, supported education, and other innovative approaches to working with people with mental health challenges and substance use problems. I think one of the key accomplishments of that group of people was the closure of the damaged state hospital. And I know that closing state hospitals in some circles is viewed as really the best thing that ever happened. And I think we did a good job of it. Other people think it's the cause of homelessness. I think in Oregon, that really can't be shown because we made that decision after an 18-year-old patient was strangled to death by staff. And they were using an approved state hospital policy called the Mums Rush. And I think Barry and Dave and Dan deserve a lot of credit for having the courage to make that kind of decision. And we committed to discharging as many people as possible by creating new community services tailored to their particular needs. And we did everything from locked intensive residential services to adult foster homes to outpatient intensive services. And we tried to get people out of those services as best we could. And we started something called the extended care management to help do that and make sure that people were moving on and not just getting stuck in places. I wanted to talk a little bit about two people who really influenced me a lot. And they were two people who are sadly not with us anymore. One was David Romprey, and he tragically passed away shortly after we started the Pure Bridges program at Oregon State Hospital. But I think one thing that I always remembered that he came up to me and he said, Bob, why do you call these programs you helped create 5-bed programs, 16-bed programs? And I said, well, David, you know, that's how many beds they have. You know that. He looked at me and he said, what do you think we're doing? Lying around prostrate all the time? I thought that was a great lesson. Point well taken. The term consumers, I think, leaves the wrong impression. And ever since then, I've tried to call these kind of programs 16-person, 5-person, and using the word person rather than patients or residents, and certainly not using the term beds anymore. Another person was Gary Scholander. And Gary, I think many of you got to know. His name is memorialized in the Scholander Empowerment Center at Oregon State Hospital, where the Pure Psychiatric Services team is based, at least in Salem. And had been a person on my caseload when I had 150 people on my caseload when I was at Marion County Mental Health. And after I had been doing administrative work and he and I had been working together on things, for example, he'd done a lot of police training. He won awards for the, the work they had done training the Portland Police Bureau. But he came up to me one day and he said, Bob, you know, you make a hell of a lot better administrator than you ever made a case manager. And Gary was never shy about making smart cracks. But the only time I ever really got him to shut up was I said, well, Gary, let me tell you something. You make a hell of a lot better friend than you ever made a patient. So Gary was just an incredible guy. I had terrible tardive dyskinesia. He was one person who felt, though, that he wanted to continue on the antipsychotics, even though it caused tardive dyskinesia severely enough that at times he was hard to understand. But I think it points out, too, that we have to respect whatever decision people make about their medications. But we do have to be more honest with them about what they can expect and not just give them minimal informed consent. No attempt at, well, let me back up just a little bit. There are more people who are heroes, in my opinion, working in the state hospital peer recovery services department. And I'm just going to name them. And I think I've got all of them that are currently working there. Rick Snook, Chris Anderson, Malcolm Aquinas, Delilah Kennedy, Cecilia Ferrello, Nishimota Fumio, and Lindsay Widmer. I think they're all there still. It's a very difficult environment to work in, as I'm sure all of you know. There's about one staff person to every 100 patients. There are about 700 patients there now. And so it's a real challenge working with the culture there that often says that it's recovery oriented. And I want to believe that they're trying to do that. And I think part of what they're doing leads that direction. But I think it's a challenge. I think cultures in state hospitals take on a life of their own, and they need constant attention and, frankly, constant advocacy and monitoring. We've actually created a scorecard that would measure whether a state hospital is actually recovery oriented. And Malcolm helped me with that, and Jack Hotchek, who I want to mention again in a little bit. So that's out there. If anybody ever wants to see it, let one of us know and we can get it to you. So no attempt at listing other peer advocates who've contributed mightily to Oregon and beyond can really do justice to the many efforts to change the system. And again, I'm going to name some of them, and I apologize for leaving some important people off. But I have to start with David Oakes, the founder of Mind Freedom International. Quick story about David. He was on the Peer Consumer Services Council that I started shortly after I was named Mental Health Commissioner. And I got a call from David one evening, and it had been a real hell-raising session. I don't even remember the details at this point, but I remember that he called me up in the evening and he said, Bob, do you still love me and are we still friends? And I would say that I still love David and I think we're still friends. I'm still involved with some of the efforts that he's doing. Other people, Kevin Fitts, I think has to be near the top of the list. I think Kevin is doing some of the more creative work right now with the Oregon Mental Health Consumers Association. Becky Child, Ann Casper, Laura Rose Masaris, Drake Eubank, Angel Prater, Laura Van Tosh, Janie Gillickson, Sharon Kane, and Michael Levacek, of course, is in that crowd too, and I've mentioned him before. Jack has been very involved, not only within the state but nationally, and I think he's doing some incredible work since he retired from Oregon State Hospital. These peers have been and continue to be involved in a variety of supports and services. And again, I'll just name some of them. The David Romfrey Warm Line, Folk Time, which Michael has recently been named executive director of, the Mental Health Association of Oregon, There are about 15 or 20 coordinators for dual diagnosis support groups, and I'll talk about that in just a second. And there are many others. And I readily acknowledge there are many others, and I apologize for leaving some people off. In closing, I wanted to mention that Corbett Monica should be considered in this crowd. And Corbett passed away 5 years ago, but he founded Dual Diagnosis Anonymous, and he should be recognized for that, and has been actually nationally and internationally. We've actually started meetings in the last 2 years in the UK. We had one of our webinars presented by Dr. Milani, who's done some really excellent research. But I think there are something like 10 meetings now in London, and we're working on starting others. DDA is now led by Doyle Smith, and Doyle is a very creative guy. I was going to start talking to him about needing to end our in-person meetings when COVID came along, and I found out he'd already started online meetings. We have those now. He started a chat box. We have people from Chicago, New York, and even St. Petersburg, Russia, who have been connecting in with that. And he's recently started a specialized program for veterans that will include a major housing project as well as other supports who've served in the armed services and who have struggled mightily, usually with mental health and alcohol and drug problems. I think that brings me to the end of the notes that I had. And Kevin, I think if you want to throw it open at this point, I'll try to respond to questions the best I can. Kevin, you still have mute on.
Oh, okay. Can you hear me now? Sorry about that.
I do that all the time when I'm.
Yeah, still getting used to this. Still can't figure out the remote controls on the TV. So if you could call me, I hear there's a Blazer game on that later I want to watch. But I've known Bob since around 1990, 1991, when he was a lieutenant, and part of the junior administration sort of stuff in the state of Oregon Mental Health Division in 1991. Got to know him through a mutual friend, Garrett Smith, that Bob talked about. It's my belief, Bob, there's questions from the audience, but I want to draw you back into some things. So start your head popping about three things that I think crucial: the future of Oregon, statewide consumer survivor peer networks, legislative action, and bringing the message to the new media. We do have guests in the audience, and I want to get to their questions first, but I might bring you back to state legislative sort of goals, state networking stuff, the intersection of that, and then also new media, bringing larger audiences to understand this struggle. So the first question is, and the people, you are free, the people on the Zoom, if you want to put your camera on and your microphone on and ask the question, or I can do it for you. The first question is from Ann. So Ann, do you want to come on, or should I ask the question? Maybe you can't.
I can ask the question from here. Bob, thank you so much for all of your work and all the great things you have done. It's wonderful over the years, and especially that first council, that's gotten everything going for all of us. My question is, what is the biggest success or successes for peers you have observed in Oregon? And the second question is, what's the biggest surprise?
Oh, sure.
Very good. Thank you, Ann.
Yeah. Well, okay. Well, I think the first really great success was the Mind Empowered Incorporated, and in particular, the most concrete thing that came out of that. People like Kevin and Michael and Scott and a guy named David Edwards, they did something that no one else, as far as I know, in the country had ever done. And that was they showed that people who had learned to live in the community and were in recovery could provide the skills and supports. And I think even more importantly than that, the hope that people can get out of state hospitals, they can lead productive lives. And I think that was probably one of the major early successes that I would point to. I'm trying to, I'm not, again, and I'm not going to do service to all of the things that have gone on. I think the David Rompre Warm Line has been a great success from everything that I've been able to see. I know it's utilized quite a lot. And I think it's an example of peers, people with lived experience who have been there before, helping people in crisis situations. Too often these suicide prevention lines just are funnels to get people onto antidepressants. And I think this is going in the exact opposite direction. So I think that's certainly another one. I think folk time is certainly in that category. I think the peer recovery services team at Oregon State Hospital is an example of that. I think the fact that it's survived for 15 years is pretty remarkable. I think Dual Diagnosis Anonymous also, which has survived in Oregon and really got a fresh start in here. Corbett had never been able to get anybody to pay attention to him until he came here. And I think, we have hundreds, if not thousands of people from around Oregon and now in about 20 other states and several other countries who are doing that. I'd be, since other people can be involved in this in kind of a dialogue, I'd be interested in your ideas too about what you see as the major successes.
Yeah, very good. Thanks, Ann, for the question. I have a question from the chat. Bob, what year did you interact with Dean Brooks? What year did Dean interact with this patient you were talking about? That's from Facebook, from Rebecca Edens. What year did Dean interact with the patient you were referring to?
The one that had been on Thorazine?
Yeah.
Yeah, that was probably about 1952, 53. That's about when Thorazine came along. I don't think he wouldn't have been superintendent by then. But it would have been right around in the early, or maybe at the latest, mid-50s.
Yeah. There was a question in the Facebook and then also a question in the chat, and let me just try to summarize it. What about particularly women leadership in this area over the years? Any folks mentioned that haven't been mentioned yet that may stick out in your mind? Nationally, internationally, What about Jackie Parrish at the at SAMHSA or CMHS a long time ago, helping support community support?
She was certainly one of the leaders, and there are a number of others that you. I mean, currently there are people like Sarah Davidow. I'm sitting here. I know the names are going to pop into my head as soon as we move on to another topic, and I'll try to bring us back.
Yeah, I just want to add you were going over one of the peer services recovery team at the state hospital, and one admission, and I think it was inadvertent, was a woman named Margaret Rose. Margaret works in that team and is a good friend of mine, and I think that it's important to put her in that mix as well. Yeah. Also want to say, for those familiar with Oregon State administration, behavioral health administration, Madeline Olson was the administrator for several years, and Barry Cast as well over alcohol and drug and mental health and DD for quite some time. So lots and lots of characters. Are there other questions from the chat? If not, there's another question from the chat. Hey, Bob, could you, Dan McLean here, could you please address the future of the consumer movement in the age of COVID-19? Dan McLean wants to know what is the future of the consumer movement during the age of COVID-19?
I realize I didn't tackle the second part of Ann's question, so I want to make sure I come back to that. What is the future of peer advocacy, peer services with COVID? I think in some ways it's made it more difficult, but one of the things that we've learned with VDA is that it can open doors that weren't there before. And as long as people are able to access through their internet, they have Chromebooks, PCs, laptops, whatever, I think it actually can open up some of the communication lines. And being able to see each other is another important piece. And I see a lot of trading of information going back now. I don't have time to stay on top of it. I know there's a lot of discussion about how to deal with legislation right now that would seek to increase the ease with which people could be committed to acute care and then even committed beyond that. I should say that I have David Cohen at UCLA doing a webinar for me on the risks of involuntary treatments, and that's coming up in, I think, May 21st. So I would encourage people to keep track of that. David has been a long time academic who really gets it.
Very good. I want to throw you a curveball about history a little bit. Remember, you mentioned the Consumer Survival Project back in the early days of setting that up. So one of the things that we're very interested in the consumer peer survivor movement is how feds and states fund things. And I generally think quick shortcuts, grants, federal grants, Medicaid funding, or general fund, state tax revenue. And one of the things that, at least to the best that I recollect it, that you took a shot out of the dark from the big providers saying, I'm going to pilot these projects with just general fund. I know that you bigger organizations, talk about the risk that stepping out and taking money that they could have used for Medicaid match for their case management programs and starting this tiny little, consumer survivor project. How was that? June Dunn, I know, was also, one of the administrators of the larger network, was frustrated with why didn't they get more revenue? Why didn't some of that funding go to them instead of this little startup project? Speak a little bit about that, if you would.
Well, there was never enough state general fund, and I'm not sure there's enough general fund now. Most of the general fund now goes into the state hospitals. State hospitals, according to Medicaid law, this is a terrible term, but they're called IMDs, and that stands for Institution for Mental Diseases, and that they're ineligible for Medicaid. That's part of why when we closed Damage State Hospital, we were able to take funding that had been used at the state hospital, converted it to Medicaid because most people were Medicaid eligible. And that's how we created, I don't think I mentioned this, we created about 200 additional placements for people every 2 years for about 6 years. And we were able to do that because we could convert general fund money to Medicaid funding. It was, it was a pretty good financial deal in that sense to close Damage State Hospital. Made good sense for other reasons too, of course. I can't take credit for setting aside general fund to fund the the Mind Empowered Community Survival Project at Damage. That was the credit for that goes to David Edwards, Dan Barker, and Barry Cast. And I think they deserve a lot of credit for the courage in doing that. And it did not necessarily make community county mental health programs or other providers that happy. But again, I think that's part of what we need in state leadership. I'll just go on an editorial here. We have to have leadership that has vision and courage. And you can often get fired for doing those kind of things. You can at least get people unhappy with you. And you have to be willing to have a thick skin and do what's right.
Yeah. Initially Mind Empowered was a SAMHSA CMHS community pilot grant for around $110,000 a year. But the bravado or the courage to say to the larger networks and the quadrant agencies across the county, we're going to take $300,000, $400,000 and put that all to a general fund startup of mental health consumers doing case management. This was before PSU got into studying, the two different case management teams. This was just the ground up, from an organization never done case management. That caused a lot of tension, and that was the first salvo, I think, in the peer and consumer wanting to get into understanding the clinical world here in Oregon. That I think caused, I think was almost revolutionary at the time, although a small amount of money. The wake of what Mind Empowered, has created here in Oregon, I think is consequential. Hey, talk a little bit about, we mentioned this earlier, about statewide networking. You're familiar that SAMHSA has been providing statewide networking grants, not for every state, but for lots of states over the years. State of Oregon put some money into what was called Oregon Consumer Network Incorporated in the early 90s. I know that wasn't your leadership, but talk about some of the decisions and the values of statewide networks and why Oregon comes back and forth, with the goal of that and having voice, and then if something happens and it kind of falls a little bit. So
Statewide consumer, persons, peers, whatever term you want to use right now, networking is absolutely critical for a couple of reasons. One, the more people you have in different locations, the more ideas you're going to be able to generate. You can also, from a legislative standpoint, get to know your local legislators, and you can be much more powerful. It's like unions. When you have individual workers or in individual workplaces, they're not nearly as powerful as if you can band together, call yourself some name, or at least begin to advocate as an entire group of people. That's how things get done, other than when you have courageous state and county leadership. I wanted to go back and talk a little bit more about the funding issues. Right now, the challenge, I think, is to get Medicaid and the CCOs to recognize the value of what peer services and supports are all about. We're actually doing that now some with the Dual Diagnosis Anonymous. Doyle has done a good job of going out and getting into the social determinants of health. That's a word to remember, and many of you, maybe most of you, are already onto that trip. It's always good to have some other sources of funding. DDA was able to get some money that had been designated for COVID and created the Veterans Project that I told you about. And I just saw that a really good question came up. When you have people who don't have the funds to either have a laptop or whatever it would take to access the internet, and they don't have Wi-Fi, how do you pull those people into the network? One of the things we wrote into the grant was funding for exactly those two things. So with the veterans who don't have that kind of access right now, we're going to be able to purchase Wi-Fi access and purchase laptops, whatever they need to get on. And so I think that's a model to look at some more. I don't know if it's been done in other places in Oregon. Maybe it hasn't been done other places, period.
You mentioned David Oakes, who's sort of a pioneer of the idea of, of speaking out, about the civil rights movement. It's not just, we've moved into the 2000s and now into the sort of peer workforce issues as well. And we don't want to forget, the consumer voice, the psychiatric survivor voice that may or may not go on and be interested in joining the peer workforce, but there's still particularly the issues of voice, customer engagement, who gets to decide what outcomes we look at. And so my point about statewide networks is, how does a mental health administrator foster a robust consumer survivor community and voice and infrastructure, because it needs support without it becoming, a board that's contesting and making life difficult for you. I mean, it seems antithetical that a mental health administrator wants to fund a very aggressive consumer survivor voice in the state to push on you. I mean, you're actually creating a more empowered consumer. And with the state dollars, are those people in political activity? Is that a fine line between political activity and supporting consumer engagement and community activities? What do you think about that?
Well, I think the state administrator who can't see the value in helping fund and support peer services and supports is missing out on a lot. I think, first of all, they're missing out on things that can be more helpful than just about anything else.
Yeah, well, let me parse you, because I think we want to, when I think about community mental health, I think about the clinical system and the social determinants of health system and the peer workforce. But the issues of consumer engagement, i.e. this SSRI had negative effects and caused, challenges with me. What the issues of the consumer and or the survivor who has been broken, hurt, or traumatized by the system may or may not be on the top of the issues of peer workforce and peer workforce issues. But significantly, and what we find, particularly in a lot of the Western states, is that the consumer survivor voice and state support of that engagement has taken a back seat sometimes to the peer workforce issues of minimum wage, better trainings, better diverse trainings, more general fund for peer workforce, which are all very primarily important to me as an advocate and a lobbyist, but also the unaffiliated consumer or survivor voice needs state support and can't be stepped into by peer workforce who are ultimately contractors of the state. So it's a different point of view. And those things need to be brought up, and we need to put more fire behind the administrators to say one is not the same as the other and they're not interchangeable.
Well, I would encourage all of you as peers, those of you who are peers, and I think that most of you who are on this are peers, is to band together and put together a proposal for what needs to happen and send it into the state and begin lobbying for it. If you need to lobby to key legislators who are receptive to these things, do that, get it into the budget.
Tell me a little bit about, in 1996 and 1997, you and Garrett Smith and some of your team at the State Mental Health Division put together an RFP for an acronym called OCTA, Office of Consumer Technical Assistance. And you had 10 directives in what you wanted that grant to achieve. Talk a little bit about the brainstorm or the mindset that you guys powwowed and to bring together that important project.
Well, I think the brain trust then was Barry, David Edwards, Larry Krieger, and Dan Barker. and I was probably in there somewhere. I'm not going to take any great credit for it. But I think that
what was the administration's need for it? Why put this out on the pavement? Why subcontract out to a consumer group to do technical assistance for consumer engagement with the mental health managed care organizations? Why was that important to do?
Well, I think it takes the understanding that peers probably can do more than just about any other group of people. And so I think it was really the vision of the value of peers. We didn't call it that at the time, people with lived experience. I think the Damish project, Community Survival Project, taught everybody a lesson about how effective this can be, and that it did not need to be a sidelight. I think it still has taken a while to really build it into the mainstream of community mental health systems. And frankly, I don't know that the CCOs have helped it all that much. Again, I'm going to editorialize here a little bit. I don't think that most of the CCOs had real advocacy from the inside to really pay attention to progressive mental health reform. And I think part of it had to do with the way the funding is set up. They have their rates set up every 2 years, I think it is. And they often don't look, I don't think they understand the values that we're talking about. And they need pressure from each area where the CCO is functioning. They need to have people like yourselves directly connecting with them and talking with them.
For people outside of Oregon, CCO stands for Coordinated Care Organization, which oversees the Medicaid managed care in the state of Oregon. And last time I knew, I think there was 13 or 14 of them across the state of Oregon, approximately, which is very interesting because they both combine behavioral health care and primary care and stuff like that. So here's another issue. You mentioned Mike Libacek, and then you also mentioned Garrett Smith. And Garrett Smith, at the time in the early 90s, state mental health divisions were looking at what they called Office of Consumer Affairs, Office of Consumer Activities, Office of Consumer Engagement. And it wasn't an individual advocacy position. It was to do system advocacy, to lay inputs and outputs to the state and the system bureaucracy managers and their workers about good and positive input from the service recipients, i.e. the consumers. Now, what was very interesting is that when you were with the administration, you guys started off subcontracting Garrett Smith as the Office of Consumer Affairs activity when he stepped over from being the executive director at Mind Empowered to be the OCA guy who would sit on management team, but was subcontracted. Fast forward into 2010, around there, 2012, Michael Libacek then took a similar position, but that was in the state, that was actually as a state employee. Brandy Hemsley currently occupies that position, and there's been a few interims in that position, like a woman named Libby Riscon. But the question is, what's the thinking about putting your Office of Consumer Affairs activities either subcontracted or have it in-house? Is there more, was there some sense that the subcontract might have more slack, that the internal one might have more, a connection to the administrators? What's the 50-50 of that kind of decision?
No, I think there are advantages and disadvantages to both. I mean, one reason for having a Michael Libacek or a Brandy or Libby inside the office itself is that they hopefully can get more access to information, more direct access to the leadership. But they also have to be careful. You can easily get yourself fired in state government for going outside the usual boundaries. And if I were to take a position like that, I would try to get some kind of commitment from the leadership that I would say controversial things, and I didn't expect to be fired for that. Now, whether you could really hold them to that or not, I don't know about that. The advantage, obviously, from the outside is that you're not beholden to what the state wants you to say, and I think you have much more freedom. You have much more ability to lobby directly to the legislature. Whereas if you're a state employee, you have to go through the whole set of tunnels in order to get access to a legislator.
Interesting. One of the things, and so we covered sort of some of the ideas of statewide network and state support, public taxpayer support, a consumer engagement about policy systems oversight and stuff like that. Talked a little bit, and the two things that I had questions for more is what regarding the Oregon State Legislature, and the biggest thing that I particularly, and I don't know, maybe 10 of my colleagues are focused on is, one, how can we get greater visibility at the state legislature? Two, how can we get the attention span on our issues when we're basically talking about, a $3 billion, $4 billion a biennium budget, and we're pushing, smaller ticket items that aren't usually, don't get to push to the front of the pack. And so one of the things I really struck when Garrett told me was that your administration asked him, when you were presenting your agency budget in front of, I think it was either Ways and Means or the Behavioral Health Committee, that Garrett to take a look at it and to say, could he in good earnest speak to some of the important parts of it and what the hope for it was. Talk a little bit about that and the value that brought to your administration, getting consumers to come on board and partnership with you around state legislative testimony and support.
Well, I think there are three parts that I would point to for working with legislators, maybe more, but the first one is get to know your local state representative and senator if you can get access to them. Another way to do it is to create an organization or two or three so that you can speak more as one voice with, hopefully hundreds of people behind you. I think the third thing is you have to learn how to communicate with legislators. They are swamped with all kinds of issues coming at them constantly, controversies, and they don't have time to listen to long speeches. Okay, I'll just put it that way. You have to learn to be very succinct. You need to have data to back up what you're asking for. You have to be very clear about what the advantages are. And if you go into 10 different things, you're going to lose them. So I think those three things are what I would suggest. And I think you're already doing many of those, but I just think those, from my experience and perspective, those are important things. Developing credibility is an important thing. And whether you're a state employee or you're an advocate, developing credibility so they know they can trust you, they can trust your information, and they know where you're coming from. They know that you're not going to ask for billions of dollars when they don't have that to give. You have to be, frankly, you have to be modest in what you're asking for.
Very good. Very good. Let's pivot now. And the last sort of thing that I was interested in, we have a question from the audience, so I'll ask that, and then we'll get back to the future of the consumer movement, the peer movement. What about this intersection too? Anybody can put a shingle in the ground and rebroadcast, activities, political activities, community organizing through the internet, moving, this migration significantly to organization communication. and what that means for the future of things, initiatives like, I want to talk about Peer Galaxy a little bit and more about Man in America, but here's the question from an audience member named Jack. What would you propose to improve informed consent? And unpack for the people, pedestrian understanding of these terms, what is informed consent? So the question again is, what would you, from our chat, what would you propose to improve informed consent?
Well, I think that two things are for peers to get as knowledgeable about each of the classes of medication, what the research says about them, what the range of side effects. I don't really like to call them side effects anymore. Joanne Moncrief, if you haven't read her, be sure to read her. And she says, look, these are not side effects of medications. These are the effects. And it's kind of a euphemism to call them side effects, but you know what I'm talking about. I think. So first of all, peers, people with lived experience, have your own experience with them, but do your research. Read, you know, the courses that I have on informed consent, the major one is free. So you can go in and see some really good information about that.
So clarity, so informed consent, we're talking about when the state or a psychiatrist gives you psychopharmaceuticals, that you get clear informed consent about the benefits, the side effects, etc., told to you or given to you in written form that you acknowledge. That I just want to draw a parameter around about what we're talking about as for informed consent.
And it has to be honest, and they have to know about the medications themselves. And frankly, I'm not sure that many of the people who prescribe medications really do know that. You know, 60 to 70% of antidepressants are actually prescribed by non-psychiatrists, largely by primary care doctors. So, and I think they're really struggling. These are issues that they don't feel very comfortable with. I've gotten to know some of the leadership of the National Physicians Alliance. They're now Doctors for America, but there are about 22,000 mostly primary care doctors around the country. And I'm trying to get them interested in learning more about these issues. And I think they're hungry. They don't have a lot of time. But particularly psychiatrists who are trained up on the Hill at OHSU, I think there's probably need for more advocacy there. They're not real comfortable sometimes because they don't know, and sometimes they're not comfortable sharing information. And you know, I'm afraid that some of them just don't really see the partnership that they should have with people who they're prescribing medications for. Actually, I've thought for a long time that if there was advocacy to require true informed consent, that could be a major leverage point in the system to begin thinking differently about how we do our mental health work. Because if the main thing is to get people in for 15-minute appointments for medication checks, that's not going to really be very effective. And we know that now. Yeah.
Very interesting. It's long been, we have a mutual friend and a gentleman named, first name David, I won't say his last name. And also he was connected with the university system in doing psychiatric education. He turned to one of my staff at a in-service training in 1999 and said, you know, I got into community psychiatry because I wanted to help people, but I was not aware of the consequence that I would be prescribing powerful psychiatric and neuroleptics for people over a 40-year period, which, you know, by me as a witness would have such consequential impact on their bodies and on their quality of life, particularly in the last 10 years of their life, and brought up the issues of pancreatic function, liver function, kidney function, diabetes. He said, you know, that wasn't exactly what I was signing up for, but, you know, which I thought was very illuminating. And we attempted to try to get a bill introduced, or at least to get interest in an written informed consent last summer for this upcoming legislation. But no one's interested in doing that because they say everything's available on the internet. Once your doctor gives you, you know, this pill for your issue, you can go research it yourself, and we don't need to be busied with that. But so the next question. Oh, go ahead.
Something about that. I think that legislation, I see that Jack just asked, what would you suggest in terms of what to do about, you know, to improve informed consent? I think legislation is a key part of it. I mean, another thing you could do other than legislation is advocate with Steve Allen and his crew and say you want that built into the state administrative rules and into the treatment standards. So
Steve Allen, is, for reference, Steve Allen is currently our behavioral health administrator at the state of Oregon. We have another question, Bob. Do you have, this is from Ann Casper. Do you have advice for administrators who are allies to peers from your experience?
yeah, listen to them, meet with them, get to
How
know
did
them.
you and I, you know, when it first started out, how did you and I become close? You know, I remember, I want to tell a story. I had a contract with Bob, with the administration from 97 to 2001, and we got off to a gangbuster start in 1999, and we're doing amazing things. We had a map, you know, they didn't put the money in our budget except for some basic administrative tasks of it, but I organized a massive conference in Eugene for consumer survivors and peers, and another one in 2000. But one of the things that we found, and we won't name his name, his first name was Norman, but went in to talk to Norman, my contract officer for your technical assistance consumer grant. And he said, and this was right after one of the conferences, he said, Kevin, you've done a phenomenal job with the Okta contract in getting consumers and peers and survivors who are angry. There's a lot of, his actually name was, first name was Norm, but he said, you know, I think you need to start building the other side of the seesaw. Where are the happy consumers and customers? And, you know, and I said, listen, you know, I put out the shingle for these conferences. I don't talk about how the community should or should not be partitioned off or, you know, or directed about that. But it was very interesting to tell that we were getting so successful that we were somewhat ringing up the phones and blowing up the emails and getting the attention of your deputies and your contract officers, which was very interesting. I don't know particularly if that was something that you guys expected early on. One of the things, we needed $40,000 in 1998 for administrative support we didn't have in our $300,000 budget. I brought in 2 senators, a couple of chiefs of staff of senator's office, a few reps, and sat across the table from Bob, Barry, and Madeline and their staff and said, what is it going to take, Barry Cast, Administrator Cast, for you and your team to sort of see the need that Mr. Fitz's group needs $40,000 more for their contract for administrative support? And that was something that I don't think that the upper administration was, one, prepared for. Two, if you would have asked them, you know, a week earlier, would that be something that consumers would be able to bring that kind of attention to your office to bring some of these issues to light? And I wondered about that particularly, of listening to voice, creating a platform, but all of a sudden that platform wants changes from the administrator who has written off, you know, who has made some promises and says he wants our voice. And sometimes I always find that, and you've said it in the press in the last couple of years, that the lifespan of a mental health administrator of a state is 18 months, 36 months. How do you build relationships with people over such a short period of time? And also too, is how do those people learn the whole system and where they're only there for 18 months or something? So
I think that's a real problem. I remember when I'd been gone for 2 or 3 years, I looked at the list of 50 mental health commissioners who I used to know, and I knew 3 of them. Yeah, so I mean, one of the challenges for mental health commissioners is, particularly if they come in from the outside, they don't have built-in relationships like Barry and I had, and it takes a while to build relationships. And yet, if their tenure could be a year or 2, they better move quickly. And the way you move quickly is to have relationships. So I think it's a real dilemma for people coming in, particularly if they come in from out of state.
Yeah. Another question, Bob, did you encounter problems with your coworkers who didn't see the value of peers? How did you handle that and keep your jobs?
It's more, if they didn't get on board, how did they keep their jobs?
When we mentioned Mike Liebachek, we mentioned Garrett Smith and Brandy, who had the Office of Consumer Affairs leadership under different time periods. Brandy has that now, but I was in that role with the technical assistance grant. And so every Tuesday morning, with you, Madeline Olson, Lynn Blackshaw, the gentleman, the Medicaid, Ralph Summers, Kylene Gower, Norm Miller would sit around your management table And here I was, a consumer voice, a subcontractor, but here I was sitting in the table talking with people about the policy directions of the administration of the mental health division. And I used to think, Jesus, 10 years ago, I was locked in Damage State Hospital. And here I am sitting around with the 6 most powerful people in behavioral health administration throughout the state, wanting to know what's my 2 cents about it. And it's very interesting. And that opportunity to have those voices of consumers in leadership intersect with management is just such a great thing. We've tried to emulate that or tried to support other states doing that, but sometimes those offices become more administrative marketing teams than they do much of anything else. So back to Ann's question a little bit more clear, deeper, not clearly, but because it's a clear question, but what about the issue of, say that you're a parent, Bob, and you realize that Bob Nikkel and the mental health administration team has now funded a team with people who come to the table saying, I have lived experience of mental health disorders or substance abuse issues, and now I'm going to be responsible in an intensive case management team for your daughter or son, but I'm a fellow traveler in that road. How does that shake the confidence of the family members, and how as administrators give comfort, stress, or the worry that parents might have of, we have a lot of discriminatory ideas what it means to be, live with serious mental health issues. How do you deal with something like that?
One of the things that I did, I wrote a blog a couple of years ago called Trauma in Common. I think what we have to recognize is that family members often have experienced their own trauma when one of their family members, is, for lack of a better term, I think there are better terms, but has a psychotic episode. It can be really scary, and sometimes they've gone through really difficult times. I don't think they often understand the trauma that it takes, that is involved when you become a patient. And I think somehow helping bridge those kind of trauma experiences is something to consider more than we do. I think sometimes there's a huge split between the peers and the NAMI types. I should mention, we had a NAMI president named Stephen Eliza for a while.
Great. Tell us, NAMI stands for National Alliance of the Mentally Ill, a federal group that has statewide groups and some county groups. So we're talking particularly about the National Alliance for the Mentally Ill, the Oregon state chapter. Is that right? Or the Clackamas chapter?
Yeah, and I'm afraid often the NAMI chapters, whether they're state or county, want to see more civil commitment. They want to see more state hospitals. They want to see more hospitals, period. And I think, it's a reflection of them maybe not understanding that those kind of settings are really not very helpful, except maybe sometimes in the short term. Although I think that the idea of peer respites is something that we've got to keep moving toward. We've got to get more opportunities for people in crisis to go immediately to people who understand the trauma that can come out of being in those kind of states of mind, and then the trauma that can come out of being in standard programs. But I think, NAMI chapters, particularly local, can have a lot more flexibility, and sometimes they're not cut out of the usual National Alliance for Mentally Ill mold. And Stephen Eliza was a guy who was president of the state National Alliance for Mentally Ill, and he was completely on board with this stuff. And he and I talked a lot, and I think he was a person who, had he lived longer, might have been a great resource.
Yeah, that's very true. So let's pivot. Let's talk about the future. Particularly, remember when we met? I think it was 9 months ago with the head of the House Healthcare Committee, and you had I can't remember what we called it, but if what we should do, COVID, how we should pivot. And I can't remember exactly how many points that we hit when we presented that to her. And also maybe it's worth mentioning the mental health report card or the mental health tabulation sort of thing you did. So talk a little bit about 3 or 4 top points of where should we chart, where should we set our rudders, where should we point our sails, and again, try to talk more, peer workforce, consumer engagement, but also more progressive, humane, more effective community mental health services. So ideas about that and hopes and worries.
Yeah, here's one of my pitches. When we start evaluating our mental health programs, what we're doing often is measuring what I call process measures, and that's things like access. How many people do we get into services? But that's different than more of a product, a results kind of thing. Getting people into services is not a result. It's something that hopefully will help get results. But I think we need to look at things that are actually, are people getting their lives back together? And how would you measure that? Well, you measure that by asking if their housing is okay. You get that by asking if they're working, if they want to go to school. What are they doing to actually move along with their lives? And as far as I'm concerned, if your access numbers just get people in for medication checks, that's not a very good measure.
Yeah. Yeah. I want to say two more comments. Someone was talking about NAMI National is slowly bringing on peers. This person says NAMI Multnomah is very open to peer support. And I should say, I really, under the current leadership of the state, the understanding and the support of peer supports and their crucial role in social determinants and building trusting relationships of mutuality. The state leadership of NAMI, I really think buys into that principle significantly. So I just want to put that out there. Yeah, it's actually a good friend of mine. Not that we don't part ways, particularly when it comes to certain civil, legislation and speaking of that, we do have two bills that are going to be in a Senate hearing, SB 187 and SB 189. One deems to extend the ability of the psychiatrist to forecast 30 days out. You may or may not be suffering from a severe psychiatric emergency. And then second one is to change the language in trial visits to individual may seek community mental health supports. It says individual shall. So we have those issues, and there's separations between district attorneys, judges, family members, and consumer voice and protection advocacy folks. And not to besmudge their character, people care deeply about these issues. But I tend to be very significant on the issue of do no harm with our service systems. Do no harm. Don't traumatize me. And also, two is the biggest issue I think we've had since you and your team has left the state of Oregon administration. And not that there is the issue. We understand that you say that you understand the phenomena of trauma, and we're thankful that you fund a think tank at the Portland State University around that. But also the issue of what are your current. We need to redesign some of our service outputs that are still traumatizing people in massive ways. And that, given the crisis of our system and the crisis of houselessness and other issues, some of these outcome studies and data looking at consumer informed or consumer empowered issues sometimes takes second or back seat. Here's another question, and this brings up one of the great points. And thank you so much for your the presentation. Especially the points about Native Americans and some of the challenges around that, just fascinating. Where are we in engaging, tribal members and people of diversity and BIPOC backgrounds in leadership of these sort of things, and recognizing their experiences are can be very different. I have a board member who says, listen, it's difficult to be Black and recovering with the substance use disorder, but it's also triply bad to be Black, have a substance use disorder, and to be caught up in the state's prisons and institutions, because they're inherently a lot of racist structures still are the bedrock of some of those practices, and those need to be broken up. But where are we in progressive leadership in Oregon engaging the voice of Black, Indigenous, and people of color? I think we have a lot of work to do. Your comments?
Yeah, I can tell you one place where that's under active consideration, and that's Salem Kaiser School Board. I mentioned Dr. Satya Chandragiri. He got himself elected chair of the board of the Salem Kaiser, second largest school district. And he just texted me about an hour and a half ago asking me for my advice on how we go about creating a trauma-informed school system. So,
Yeah,
it's starting to happen. And,
yeah, we still do. There's been some good movements with Office of Equity Inclusion at the state of Oregon, and there's been some movement in that. However, if we look through our dominant mental health administrations at our largest counties, and if we look through, the state behavioral health administration and even the behavioral health administration within our state hospital systems, we have a lot of movement to do to get voices representing of Oregon at the table. And that is a long time coming. I think there's some forward progress, but we need to redouble our efforts because it's just not happening consequentially. I mean, I really believe that strongly. What about the issue where this has also been a debate? Is sometime under the sun, are we going to drop the idea of peer and just talk about humane systems that are effective and have beneficial outcomes? Is that something that we could build a bigger audience of, that everybody has some investment in? Why is our mental health system broken? Why do the outcomes stink so bad? Why are we spending so much on psych meds and hospitalization and police interventions? How do we build a bigger tent? Because sometimes I think we talk in our acronyms about the peer world or consumer policy sort of things, and Joe Q Public can't really sort of figure out, is this a community I should have a voice or I could put an elbow to? What do you think about that?
Well, I think one of the problems, one of the challenges in getting people on board and interested in all of this stuff is that most people in the grocery store still think that if you have a mental health problem, it's a mental illness and it's a chemical imbalance. I'm working right now, and I'm almost finished with it. There's a woman who's involved with the legislature in Montana who had her own crisis a couple of years ago. She's worked in the digital world. She's got a master's degree in German and a master's degree in research. And she and I have put together a 2-page, what she calls knowledge engineering document that really lays out why the title is Why the biomedical model must evolve. And we've been very careful about wording. We're talking as we go into it about how that model hasn't worked very well. We give concrete examples, 2 or 3 of them. We talk about what would work better. We mention things like peer services and supports. We talk about reducing reliance on psychiatric drugs. And we're just about ready to put it out there. I think we're, in a week or 2, I can send it to any of you who want to see it. But I think that's one thing we need to do, is change the paradigm that people tend to think about mental illnesses in.
Yeah, good point. One other question here from the chat. How would you set up the public safety system, meeting people on the streets? Would you suggest peers and EMTs? This is a good point because, you've heard of the CAHOOTS program. I think that's the acronym out of Eugene, Springfield, and the interest of trying to pilot that in the Lentz neighborhood in Portland. What do you think about that? Let me just take a devil's advocate. There's some people that fear, people who fear police intervention, but there's also people who fear, and let me just be crude. Remember the cartoons of the 50s and 60s of the white van with the butterfly nets? There are people who fear those people and those kind of interventions as well, significantly, because it means a place of institution that maybe they've been to previously that didn't work. So what do you think about street engagement for people in extreme states? How to finesse that in a way that comes out beneficial for the person, not just the bureaucratic system, getting a new program and being able to spotlight that on the evening news?
Well, the work that Gary Scholander did with the Portland Police Bureau as a start in that direction has helped them get to see somebody who's been through that situation themselves. Gary would talk openly about the fact that he heard 17 different voices in his head, and half of them were telling him he was the greatest human being who ever lived. The other half told him he was a piece of shit. And he said the 17th was a girl, and he would tell him she's really cute. He would really just, not literally, but psychologically disarm the police. And and that's one piece, is helping law enforcement understand what this is, what it's like to be a person. He would roll up paper cups, sheets, and he would have one officer, be a voice on one ear, the other one, and then he would have the other officer try to interview them. So helping people in law enforcement understand what this is all about is one step. I think having peers involved, having peers who can steer people into peer respite programs, all of those kind of things. We need to make more resources available to law enforcement, because right now they're just doing the only thing they know how to do with their own biases intact.
Yeah. So understanding the fidelity of the peer support, say there's 3 people, 4 people that go out on a mobile crisis outreach, you have 2 or 3 clinicians and 1 peer. The clinicians are thinking in ways of medical intervention. You know, we're not here to provide a panoply of menu of choices. We're here to address and triage the situation. The peer as the guide to what supports best what the consumer wants and needs in this situation. How can I be an ally of mutuality and support of their choice? Sometimes the clinical team wants to go in a aggressive direction about containment or, you know, medication administration, and sometimes the peer, being the odd voice out, is sometimes in a challenging situation there. How do we keep that sort of thing happen? What I described is I actually have a peer that worked for one of our mobile crisis teams and was in that conundrum 2 or 3 times and ended up moving to a different department.
I think it's a huge challenge. We have to retrain not just psychiatrists, but also nurses, social workers, case managers, anybody who's in the field.
Yeah.
And we're a ways from that. That was the idea behind Bob Whitaker starting the continuing education project.
Good point. I was going to tell us that. Tell us again what the Mad America website is, and then tell us a little bit more about the continuing ed project that you run there. I think that will be, and then at the end, I want to put in a plug for Peer Galaxy and tell you what that is. I think you already know to some degree, but go ahead. Tell us a little bit about what Mad America is and what you're doing there with the continuing ed and your goals. Thanks.
Yeah, there are really 2 parts. There's Mad America and there's Mad America Continuing Education. They're really somewhat separate. Mad in America, I'm guessing that many people are already connected into the website. It's a journalistic approach in that Bob Whitaker is an investigative medical journalist, and he tries not to take political positions, but he tries to get information out there. He has 2 different major categories: reports. For example, he has a report on the ineffectiveness of involuntary outpatient care. And if you know Bob at all, he's a very careful researcher. He doesn't put anything out there unless he's researched it. He also has one on the risk of the standard prevention hotlines. So those are the category of reports. And then he has blogs. There's a ton of blogs, and they often disagree with each other. I've published or posted about 20, 25, and I either get people hating my guts or loving what I've done. So you
How is that website, that enterprise, how is that supported? How is that funded?
Well, we've had some philanthropists who have been supportive. So that's one of the ways. It's a constant struggle to get funding. We also had the Foundation for Excellence in Mental Health Care, and I think they're still providing some funding. They're now called Open Excellence, but they've provided Bob with some funding for that.
Very good.
The other project is the one that I direct, Mad America Continuing Ed.
How long has that been going on for, the Continuing Ed Mad America?
5 years.
5 years.
And we have about 30 presentations up there. And most of them are free. If anybody wants to take one of them that has a cost to it, just let me know and I'll give you the free code.
That's an you know, we must have a couple thousand visitors, Bob. So you're going to get overwhelmed with free code invitees.
I'd like to have that problem.
Yeah, very good. Speaking of that, what are some topics in the last couple months or topics in the future that you've looked forward to doing with the Continuing Ed project?
Say that again. I got distracted by Ann Casper posting.
Oh yeah.
Very nice pictures. So.
Yeah, it was very nice.
Say it again. I'm sorry.
Just any continuing ed topics coming up, any in the last couple of months that stick out of your mind that you wanted to sort of give people a shape, and then we'll wrap it up.
Yeah.
You mentioned that Malcolm. Tell us about the Malcolm training. I know that some people in our audience are familiar with that. What was that training on particularly?
He did one on system change. He also helped with the informed consent series, but he did one on system change from the perspective of the state hospital. How do you do that? And that's a huge challenge. Malcolm has been a school teacher, and when he puts together presentations, they are very well organized. and he's done some of the best that I've ever had. In December, we had Dr. Milani from West London University do one on her study on dual diagnosis anonymous. Last month, January, we had Dr. Robert Drake, and he did one on system improvements for using evidence-based practices, and he emphasized supported employment and supported housing. And Bob and I have known each other for over 30 years. He helped me with research on the NIMH dual diagnosis demonstration project. And next week we have two physicians from Chicago. They are involved with something called VEN, and they work with people from racial low-income communities, and I'm not going to try to explain what they're going to talk about because I'd rather let them do that. But we have them coming up on February 11th and March 11th. We're looking at a person for April who I can't talk about quite yet, but he's a really fascinating guy. And then we have in May, we have David Cohen, as I mentioned, talking about the risks and dangers and drawbacks of involuntary treatment. And then in June, I'm starting to schedule one from New York City, Manhattan. There's an organization called East Side Institute. And they did a town hall a couple of months ago, and they're really good folks. And they have a model called Creating Your Own Mental Health.
Very good. That's all fascinating. I'm a hungry intellectual. I find that series, the different series that you've done on withdrawal of suicidality, just fascinating. And I couldn't imagine anybody else being sort of the idea person to go out and find the actual interesting talking heads and scientists and researchers and journalists. Just a fantastic job with that project. I also want to tell you, and also, so we're at 1:30, so I want to wrap it up. Want to thank you tremendously. We would not, I'm a big fan of the previous architecture. Oh, we have another. Thanks, Bob and Gina. You have improved our lives. How sweet. That's a beautiful message. That's for sure.
Gina's listening in here, so I'll make sure she sees it. Okay.
Yeah.
Thank you.
That's no joke. The consequence, and I think Laura Rose Masaris might have said it in the Facebook chat column, the consequence of one or two administrators taking a risk, going out and engaging, looking for what works best, what's novel, what haven't we tried, what may be a little bit risky to the larger industry that shakes up their funding part of the pie. We would not be here in 2021 with peer respite in the state legislature, with the Peer Services Recovery Group at the state hospital, with the Oregon Consumer Advisory Council being a mandated state advisory council. We would not be here in the peer workforce with almost 5,000 plus peers certified without the early architecture of our allies and friends who were willing to support us early on when we were not probably ready for prime time. We didn't know about relationships and trust. A lot of us resented authority and had been sold down the river or broken promises or just ignored. Sometimes I look back to the administration that you were either led or were a deputy to, and it makes my heart ache because I think to some degree with this Medicaid managed care and folding behavioral health into our managed care, largest organizations, the voice of primary behavioral health, or community mental health has taken a back seat, particularly, and the initiatives, that we know that we need initiatives that spark and support consumer voice and consumer outcomes, the issue around civil rights and having voice around that. This feels like that we have, not that they were the glory years, Bob, but certainly I always said, even though he's frustrated with me because our consumers are making noise and blowing up the email list, they have a commitment and he knows in his heart that this is the right thing to do. And maybe that made some grief, but we built 3 or 4 generations of passing the torch forward. And you were a principal, definitely a principal of that in the late 80s and moving forward. I really love you as a friend. You're a lifesaver for me, as a pitch in, AA sponsor when I was dealing with my alcoholism. So I just want to say I love you, and for the rest of the community, I think they love you as well. Also want to say put in one plug about, I asked about the future. There's a website that is at least at this point for the next year through the state of Oregon, called peergalaxy.com. You talked about dual diagnosis. There's other groups like Hearing Voices groups, AA groups, yoga classes, wellness classes, everything under the sun in a panoply of an online directory funded by, by a modest contribution from the state of Oregon Behavioral Health Division, called peergalaxy.com. And my point, this might seem boring because we're talking about policy and system structures and funding mechanisms, but the goal is to save lives, not just to save lives, but the goal is to restore, renew, and refresh lives once they get out of our systems. And the leading edge of that is the consumer survivor movement, the peer voice, and the administrators and allies who befriend us, and we work together in solidarity. So I love you from the bottom of my heart. Do you want to give your contact? You want to give out your email if people want to follow up with you individually, or can I give it
I
out?
do want to say to Margaret, I want to say to Margaret Rose, I'm sorry I left you off. I really feel badly about that. So I didn't want to finish up without apologizing. My email address is all one word, BOBNIKKEL, Bob Nikkel, BOBNIKKEL @gmail.com. BobNikkel@gmail.com. I should warn you that Gmail is sending stuff to my trash folder that I really want. So if I don't respond in a day or so, let me know somehow. And I keep checking my trash folder, but I'm just saying that's one of the glitches that I'm having right now.
Well, very good. Okay, well, thank you. We are a little past 1:30. We wanted to do 90 minutes, but such a wonderful history. You can also check out at the Oregon Mental Health Consumers Association Bob's notes for this, and you have his email. And we look forward to continue next Saturday. We will have a guest named Rachel Flanagan. She will be talking about the mind and meditation, which looks also very fascinating. So thanks again. This is Fittsian Dialogues. We are live on Facebook and in Zoom at noon most Saturdays. Thanks a lot. And thanks again, Bob. I love you, buddy.
Thank you. I love you all.